Very, very warm good evening to all of you. Thank you again for joining for this yet another session of Vertigo Grand Rounds. So today I'll go straight to the topic. It's been last few days that ChatGPT has been there last few months. That there has been a lot of buzz around it and what can be done, what it is going to do to jobs, what is going to happen to our roles. All these things have been that kind of discussions have been happening. What I thought is I've been using the ChatGPT model for a few weeks now, and I thought the best way of knowing its potential, its limitations, and the way forward is to actually pose some real clinical cases and questions and see what it has and see what it can offer us. So I'll just start sharing the screen. So this is the ChatGPT. I'm sure you're all able to see the screen. So what we do here is there are some case discussions which is part of our course. Okay, the course that we conduct, the 10-week module with 10 weeks of online and 1 week of offline. In that, there are some case discussions we do. And some of the case discussions are actually taken from a textbook called by Joseph Fuhrman et al. Very nicely worked up cases with a lot of details about every patient, and the final diagnosis have been achieved. So I chose 5 of those cases and just put it to the model and wanted to see what comes out of the model. The first case that I chose, I'll just read from there only, is this patient. What could be the diagnosis is the question that I asked. And I'll read the answer to you. A 50-year-old man who worked as an electronics repairman complained of frequent dizziness and lightheadedness that had gradually worsened over several years. He rarely experienced vertigo. The patient's symptoms included sense of disequilibrium and a feeling of generalized weakness and faintness. These symptoms were especially noticeable on first arising and on standing for more than several minutes in one place. The patient had no complaint of hearing loss, tinnitus, paresthesia, air hunger, palpitations, fear, or anxiety. The family history was positive for adult onset diabetes mellitus and negative for neurologic or otologic disease. The patient stated that he had recently been tested for blood sugar level and this was normal. He was not using medications. Patient's records indicated that a complete blood count, thyroid and adrenocortical steroid function test and a screening electrolyte battery were normal. This was what was provided to the model. When we asked this question, the response that this came with is this. Based on the information provided, the patient's symptoms suggest a possible diagnosis of peripheral neuropathy, which is damage to the peripheral nervous system. The gradual onset of dizziness and lightheadedness, sense of disequilibrium, generalized weakness, faintness that worsen over several years are typical symptoms of, is what it is telling. We know that this is not right. Okay, we know that this is not correct, but this is what it is saying. Additionally, the fact that the patient works as an electronics repairman may suggest exposure to toxic chemicals or repetitive motions that could contribute to peripheral neuropathy. So this is a suggestion that possibly, and it can be true. It is important to note that conditions such as inner ear disorders, cardiovascular disease, and central nervous system disorders can cause similar symptoms. Therefore, further testing and evaluation by a medical professional such as a neurologist may be necessary to confirm the diagnosis and to determine the underlying cause of peripheral neuropathy. So there seems to be more of generalized comments and generalized suggestions when I provided this much of information. Let us see what happens if I provide the model a little more additional information that is again from the same textbook of cases. The patient's examination revealed a blood pressure of 130/85 while he was supine with a pulse of 70. After 3 minutes of standing, his blood pressure was 90/60 and his pulse was 90. The patient stated that he was experiencing his typical symptoms of faintness and asked to sit down. He felt less symptomatic almost immediately on sitting. The remainder of the neurologic examination was normal. During Romberg's test, the patient complained of feeling lightheaded but he did not fall with his eyes closed and was able to stand on a compliant foam surface without difficulty. The neurotologic, and otological examinations were normal. The moment this was provided, the answer that came out is like put, gave the diagnosis. Based on the patient's examination results, it is likely that the patient is experiencing orthostatic hypotension, a condition in which the patient's blood pressure drops significantly when they stand up. This can cause symptoms such as dizziness, lightheadedness, faintness, which are consistent with the patient's complaint. The drop in blood pressure from 130 out of 85 to 130 by 85 to, I'm sorry, I'm reading it like marks, 130 by 85 to 90 by 60 after 3 minutes of standing, along with the increase in heart rate, supports this diagnosis. Additionally, the patient's symptoms improved when he sat down, further suggesting orthostatic hypotension as the cause of his symptoms. The normal neurologic, neurotologic, and otological examination indicate that the patient's symptoms are not likely due to any underlying neurological ear-related conditions. Further evaluation, including blood tests to check for conditions such as anemia and blood sugar imbalances, as well as medication review and adjustment, may be necessary to manage the patient's orthostatic hypotension and alleviate its symptom. So basically, what this particular response tells is, of all the findings, the model is capable of actually picking up that particular significant finding and also telling, again, general comments about the rest of the finding. Then I gave further information again from the same textbook. This patient was treated with support stockings, abdominal binders, and increased dietary sodium intake and fludrocortisone, 0.1 milligram twice daily. He was also advised that when changing from supine to a standing position, he should first activate the leg muscles before arising slowly. And once upright, he should begin ambulation as soon as possible to avoid standing in one place for more than a very brief time. The patient responded favorably to this treatment, but still experienced some dizziness and lightheadedness when standing. Now, when I gave this additional information, his response to treatment and all these things, it's encouraging that the patient responded favorably to the treatment of support stockings, abdominal binders, increased dietary sodium intake, and fludrocortisone. These interventions are aimed at increasing blood volume and improving blood flow to the brain, which can help alleviate symptoms of orthostatic hypotension. The additional advice to activate the leg muscles before standing and to avoid standing in one place for too long is also helpful in managing orthostatic hypotension. However, it is noticed that the patient still experiences some dizziness and lightheadedness when standing, indicating that further interventions may be needed. The patient's medication regimen should be reviewed, and the dosage or type of medication may need to be adjusted to better control the symptoms. Other interventions that could be considered include increasing fluid intake, using compression stockings, adding additional medications such as midodrine, which can help raise blood pressure. A referral to a specialist such as a cardiologist or a neurologist may be warranted for further evaluation. So this is the kind of transfer. If I have another additional doubt, I will ask, okay, and then get a reference, okay, and see what happens. Okay, the rise in pulse rate with fall in blood pressure raises the suspicion of hypovolemia. Maybe some source of internal bleeding or sepsis. Tell me why my suspicion is wrong. Okay. Okay. Oh, it's not able to generate a response. Sometimes this happens, so don't bother about it. So let us try to give that again. So now one more, we'll go to the next one. Let us see. Okay. This is one more thing that keeps happening. It asks a human. AI model is asking a human to verify that I am a human. So I will try to verify that I am a human. It's checking the browser. These are general things. Okay. Some measures that they are put in to prevent people from overloading those browsers with unwanted requests. I mean, from from other AI, whatever bots asking a lot of questions and overwhelming the system. So to prevent that, they do this. So I'll take the next question that I asked the model. Okay. A 70-year-old man presented with complaint of unsteadiness while standing. The patient's symptoms had been present for past 7 years and were gradually worsening. He complained that after standing for 2 to 3 minutes, he felt very unsteady and fatigued, needed to lean against something for support. He did not complain of dizziness. He was asymptomatic when sitting or walking. There was no positional dizziness. His past medical history was significant for bilateral hearing loss and arthritis. His surgical history included resection of a colon cancer and prostate surgery. Okay, this is. I will share the books. Okay, don't worry. He was okay. There was no positional dizziness. His past medical history was significant for bilateral hearing loss and arthritis. His surgical history included resection of a colon cancer and prostate surgery. Medications included a cholesterol-lowering agent. He did not consume alcohol. He had no complaints of double vision, numbness, weakness, confusion, or difficulty. This is the kind of information we first provided about the patient. So then there was a generalized answer based on the information provided. The patient complained of unsteadiness while standing could be due to various factors. One possibility is a neurologic disorder such as Parkinson's disease or cerebellar ataxia. Another possibility is peripheral neuropathy, which can cause loss of sensation and muscle weakness in the leg. Additionally, arthritis can also contribute to difficulty with balance and walking. All of those things are very sound suggestions. It is like a senior talking to you when you ask him these questions, and then senior tells all the possibilities. Like, it is important to perform a thorough neurologic examination to assess the patient's gait, muscle tone, strength, reflexes, and coordination. It's telling where to concentrate on. Imaging studies such as MRI or CT scan of the brain may also be helpful in ruling out any structural abnormality. Blood tests to evaluate for vitamin deficiencies, thyroid function, and glucose levels should also be considered. The patient's history of colon cancer and prostate surgery is also important to consider, as it may suggest the possibility of a metastatic disease or a paraneoplastic syndrome affecting the nervous system. Overall, the further evaluation and testing are needed to determine the underlying cause of the patient's symptom and to develop an appropriate treatment. So it is not hazarding a guess based on the information, all the different possibilities, and then what to concentrate during the physical examination, what to concentrate during the investigations, and also the possibility, it is suggesting the possibility of either metastasis or a paraneoplastic syndrome itself causing the symptoms. Now, when we provide additional information about what we got from the clinical examination, neurologic examination revealed a palpable tremor in the lower extremities while the patient was standing. This tremor was noted only after the patient had been standing for 1 to 2 minutes. No upper extremity tremor was seen at rest with action or with attention. The remainder of the neurologic examination was normal with the exception of mildly impaired tandem gait. Otologic examination was normal. Neurotological examination was normal. Now, when we provide this specific finding, revealed a palpable tremor in the lower extremities, it picked up that point and it said, the model, the presence of a tremor in the lower extremities after standing for 1 to 2 minutes suggests a possible diagnosis of orthostatic tremor. That's it. So it just goes there and gives the diagnosis. Orthostatic tremor is a rare condition characterized by a high frequency tremor in the legs when standing upright, which typically disappears upon sitting or walking. The tremor is usually not visible to the naked eye and may require electromyography for detection. So in fact, the authors also have told that it's a palpable tremor. It's not a visible tremor. So it is telling that, emphasizing that aspect of that. However, impaired tandem gait suggests that there may be some impairment in cerebellar function also, which may suggest a coexisting diagnosis. It is important to consider other causes of tremor such as Parkinson's disease, essential tremor, and drug-induced tremor. A more detailed neurological examination and further testing, including imaging studies and laboratory tests, may be necessary to differentiate between these various causes of tremors. Normal otologic and neurological examination suggests that there is no underlying vestibular or auditory dysfunction contributing to the patient's symptom. Management of orthostatic tremor may include medications such as gabapentin, clonazepam, and primidone, as well as physical therapy and occupational therapy. Just see this. The suggestion of gabapentin came even before we told the patient that the patient was actually told the model that the patient was actually given gabapentin. Okay. So let us see, we'll provide the additional information to the patient, to the model. VNG ocular motor function was normal. There was no positional nystagmus and caloric responses were normal. Rotational responses were normal. Amount of sway during posturography was normal. However, the patient's record during posturography revealed extremely high shear force. Vestibular evoked myogenic potential were normal. An MRI scan of the brain revealed deep white matter changes consistent with patient's age. So now what the interpretation of the investigations that we provided. The VNG suggests, video nystagmography results suggest that there is no peripheral vestibular dysfunction contributing to patient's problem. Normal ocular motor function, caloric responses, and rotational responses indicate that the inner ear and vestibular nerve functions are functioning properly. Normal vestibular evoked myogenic potential suggests that there is no saccular or inferior vestibular nerve dysfunction. However, the finding of high shear, that is horizontal forces during posturography, suggests a central nervous system dysfunction affecting postural control. This may be related to the deep white matter changes seen on MRI, which are consistent with the patient's age. The deep white matter changes may be due to small vessel disease, which is a common age-related finding. Other possible cause of deep white matter changes include chronic hypoperfusion, inflammation, and demyelination. Further evaluation such as neuropsychological testing may be necessary to assess the extent of any cognitive dysfunction related to deep white matter changes. Treatment may involve physical therapy and or occupational therapy to improve postural control, as well as management of any underlying medical conditions such as hypertension or hyperlipidemia to reduce the risk of further deep white matter changes. So, see, one of the things that this model actually came up with here was a suggestion of a particular medication called gabapentin. Okay, I want to mention this particular thing because when you go to Fuhrman's textbook and see what exactly was done for this particular patient, given a diagnosis of orthostatic tremor, and the patient was treated with gabapentin 100 mg 3 times a day and was referred for vestibular. So this, we didn't provide this information, it gave a suggestion, and before even this model existed, this book existed. Before even ChatGPT was there, this book existed, and the authors, the best choice of medicine that the authors of the book thought appropriate for this patient, that was also the medicine that comes under one of the suggested diagnosis for a rare disorder called orthostatic tremor. So which is significant, okay, which is significant coming from an AI model. Okay. Now let us go and see what the third question that I asked of the model. Okay. I did a little more. I wanted to probe this a little more, go beyond just taking the suggestion. So I'll just demonstrate that to you in this case. A 36-year-old female librarian presented with a complaint of episodic loss of balance. These attacks had occurred approximately once each month during the 2 years before evaluation. They were stereotyped and characterized by an abrupt loss of balance, causing the patient to feel that she was being pulled to the ground. There was no associated vertigo or nausea. The patient was unaware of any precipitating factors. No episodes occurred while the patient was driving. However, on several occasions, she suffered bruises associated with falling, which means they were intense falls. The patient was evaluated by her primary care physician, who was unable to reach a diagnosis. That evaluation included a negative MRI scan of the brain and blood studies, including hematologic, metabolic, and rheumatological parameters. When this amount of information was given to this model and waited for the response, the patient's symptoms suggest a possible neurologic issue such as a vestibular disorder. However, the negative MRI scan of the brain and blood studies make it less likely that the cause is a structural abnormality or systemic disorder. Okay, we can give it to it that it is, the reasoning is right and the fact is also right, may not be relevant to this patient. Further evaluation may be necessary, such as a referral to a neurologist or an ENT specialist for a more comprehensive assessment of the patient's vestibular function. Tests such as electronystagmography or video nystagmography can help if there is an underlying vestibular dysfunction. In addition, patient should be advised to take precautions to prevent falls, such as using handrails when walking up or down stairs, wearing non-slip shoes, and avoiding hazardous activities that may increase the risk of falls. So far, there is no specific suggestion of a diagnosis. It is more like, okay, possible neurologic disorder, such as a vestibular disorder, something like that. But let us provide a little more additional information to this model. The patient and her family were adamant that the patient did not lose consciousness during these episodes. This is the information we are providing. Despite the abrupt onset and seemingly immediate fall of the patient to the floor, she remembered each episode and was alert, oriented, and conversant immediately afterward. There was no apparent post-ictal lethargy or confusion. The patient noted no association between her episodes and menses. Her family history was significant. Her mother and sister suffered from typical migraine headaches. Also, the patient's history was significant for sick headaches as a teenager, usually associated with menses. These headaches had stopped approximately 15 years before evaluation, and the patient was in her early 20s. She was not currently using any medications. The moment this was given, just see what is the solution. The patient's symptoms, family history of migraine headaches, and previous history of sick headaches suggest, just see the way it is summarizing everything in one sentence. Patient symptoms, family history of migraine headaches, and previous history of sick headaches. The ability of that model to actually put multiple sentences, okay, just in one sentence is really amazing. Suggests that our episodes of loss of balance could be related to a type of migraine called vestibular migraine. Vestibular migraine is a type of migraine headache that is associated with vertigo or dizziness, but not always with headache pain. In some cases, it causes a sudden loss of balance similar to what the patient is experiencing. Further evaluation is necessary to confirm the diagnosis of vestibular migraine. Treatment options may include medications to prevent or manage migraine headaches, as well as strategies to manage vertigo and balance issues such as vestibular rehabilitation therapy. Okay. The patient may also benefit from lifestyle modifications such as reducing stress and avoiding triggers that may worsen her symptoms. It is important to note that other potential causes of the patient's symptoms such as vestibular disorder, neurological, should also be ruled out through further evaluation. See the beauty here. Okay. It is able to tell that the patient's fall. See, we just told the patient has been falling. Okay. Had attacks, episodic loss of balance, complained of episodic loss of balance, and that was abrupt loss of balance causing the patient to be free. See the way it has actually understood and paraphrased it, and it is telling us here. Okay. In some cases, it can cause a sudden loss of balance similar to what the patient is experiencing. Okay. So this sudden loss of balance, that is something that the model is understood from what we have told. That okay, and it is telling migraine cause this kind of thing. Now, additionally, we provided more information. The general neurologic, otologic, and neurotological examinations were normal. Now, I'm just telling these are all normal. How can it be vestibular migraine? I'm trying to challenge that model to ask the question. So now it is telling, despite the normal findings on examination, the patient's history and symptoms suggest a potential diagnosis of vestibular. It is insisting that it is vestibular migraine and that it can be normal. See, further evaluation such as vestibular function testing or imaging studies may be necessary to confirm the diagnosis, rule out other potential causes. In the meantime, the patient may benefit from strategies to manage her symptoms, such as avoiding triggers that may worsen her episode, reducing stress, and engaging in regular exercise. Medications such as beta blockers, calcium channel blockers, or tricyclic antidepressants may be considered to prevent manage migraines. Our choice medicines are being told beta blocker, calcium channel blocker, and tricyclic antidepressant. Vestibular rehabilitation therapy, it is a type of physical therapy that focus on improving balance and reducing dizziness, may also be helpful. It's important for the patient to follow up with their healthcare provider regularly to monitor symptoms and respond to treatment. Now, we provided more information. The patient was advised to restrict her consumption of foods known to provoke migraine and was treated with a combination of hydrochlorothiazide, dimetrin, and salt restriction for possible endolymphatic eye drops. She continued to have further episodes of loss of postural control for additional 2 months. Diuretic therapy was discontinued and the patient was started on calcium channel blocking agent. She immediately noticed a reduction in the frequency of her symptoms. The patient continued to use this medication for 6 months, during which the attacks tapered off completely. She then discontinued all medications and has been symptom-free. Based on the patient's response to therapy, she received the presumptive and uncertain diagnosis of drop attacks in association with migraine. Let us see the response. It is promising that the patient's symptoms improved with treatment. The use of calcium channel blocking agent may help to prevent or manage her migraines, which in turn reduced her episodes of loss of postural control. The way it is able to reason, see, the calcium channel blocker has managed her migraine, and management of migraine in turn has reduced her episode of loss of postural control. Okay, it is able to really understand like a human being what has happened and paraphrase it and tell us. Okay, the diagnosis of drop attacks in association with migraine is a presumptive uncertain one, and there are no specific tests to confirm this diagnosis. It is important for the patient to continue to monitor symptoms or follow up with her healthcare provider regularly, especially if she experiences any recurrence of her symptoms. It may also be helpful for the patient to keep a headache diary to track any potential triggers or patterns related to an episode of loss of postural control. The patient does experience a recurrence of her symptoms. Further evaluation may be necessary to rule out other potential causes, such as a vestibular disorder or a neurologic condition. Treatment options may include adjustments to medication, vestibular rehabilitation therapy, or other interventions as recommended by her healthcare provider. Now, this is what it told. Now, I wanted to okay, fine. I'm not happy with this particular, okay, I'm really not comfortable. It is still presumptive for me. So please provide some citations to support the claim that vestibular migraine causes drop attacks. I'm asking for citations now. Now it is saying there is limited research on the association between vestibular migraine and drop attacks, and the available evidence is largely based on case reports and case series. Here are a few references that discuss this association. Lempert, migraine associated vertigo, Lopez, classification, diagnostic criteria, management of vestibular migraine, a consensus document by Barney Society, International Drake Society, Dietrich and Brandit, episodic vertigo related to migraine, 90 cases, vestibular migraine, Stroop and Brandit, migraine and vertigo, Journal of Neurology. It's worth noting that drop attacks can have a variety of causes, and further evaluation may be necessary to determine the specific underlying cause in each case. But then it provided citations stuck like that. Okay. So this is one. Let us see one more case. What I did here was within the ChatGPT model. Okay. Again, artificial intelligence is asking human being to confirm that I am a human. Okay. What I did was I used another model. Within ChatGPT, there is a GPT-4. GPT 3.5 versus GPT-4. GPT is the latest generation, with the claim being the more advanced reasoning, more advanced reasoning. But let us see whether GPT-4 is really better. This is very important because what happens as these models grow, what happens as they are trained more and more, so-called better. Do these models become better? Do they become worse? Do they become? So that question I wanted to ask. So I asked GPT-4 the same question, and the same question I asked to GPT 3.5. Let us see the difference. A 71-year-old man presented with a complaint of oscillopsia and gait instability. The patient noticed that his balance was especially worse in dimly lit environment and when walking on uneven surfaces. The patient was bothered by complex visual environment, including grocery store. The patient had fallen without injury on several occasions. The patient's history was significant for an ileostomy 20 years earlier associated with severe postoperative infection and a 3-month hospitalization, during which he received intravenous gentamicin. At that time, the patient experienced oscillopsia, gait instability that largely resolved. During the past several months, the patient's symptoms recurred. Now see the difference of response of GPT-4, the later model. It has suddenly become less confident. It has lost its confidence. See, I am not a doctor. Disclaimer, it starts with I am not a doctor. But based on the information provided, the patient's current symptoms may be related to a combination of factors, including past exposure to gentamicin, age, and potentially underlying neurologic condition. Gentamicin is an aminoglycoside antibiotic, and one of the known side effects is ototoxicity, which can lead to vestibular and auditory dysfunction. Given the patient's history of a severe postoperative infection and a 3-month hospitalization with intravenous gentamicin, it is possible that some degree of vestibular dysfunction could have developed at that time. The patient's symptoms of oscillopsia and gait instability, which largely dissolved after the initial exposure, may have been related to this. It is worth noting that as people age, they may experience a decline in vestibular function. Which can contribute to gait instability and difficulty maintaining balance. These could be exacerbated in dimly lit visual environment, such as grocery stores, may also challenge the vestibular visual symptoms, making it more difficult for the patient to maintain balance. Considering the patient's age and medical history, essential thorough evaluation to be conducted by a healthcare professional. This could involve assessing the patient's vestibular function, neurologic status, and visual system. A referral to a neurologist or otolaryngologist may be appropriate for further evaluation and management. Potential treatment options could include vestibular rehabilitation therapy, medication adjustment, or lifestyle modifications to improve the patient's balance and reduce the risk of falls. See, the overall, there is no specific diagnostic suggestion, but it is in the right direction. It is telling that gentamicin could have caused the problem. It is telling what all gentamicin does to the body. Okay, so what happens with age? A lot of things are coming. Then I give more. general examination was normal. Neurologic examination revealed full extraocular movements without nystagmus. The remainder of the neurologic examination was normal, except that the patient had gait ataxia with a wide end base. Romberg test was negative. Otoscopic examination was normal. Decreased audibility to finger rub was noted in both ears. Patient's visual symptoms could be reproduced by applying a gentle vibratory motion with the index finger just lateral to the outer canthus of the eye, while the opposite eye was occluded. On neurotological examination, there was no nystagmus behind infrared goggles. On head thrust testing, refixation saccades were noted with head movement, both to right and to the left. During ophthalmoscopic testing of VR, the optic discs were noted to move with the patient's head movements rather than remain stable in space. Patient was unable to stand on compliant form with the eyes closed without falling. Now, what is the answer? I am not a doctor, but based on the information provided, it appears the patient is exhibiting signs of vestibular dysfunction, which could be contributing to his oscillopsia and gait ataxia. See this. The moment you give more additional information, it is able to be more emphatic in telling that it is vestibular dysfunction. The patient's inability to stand on compliant foam surface with eyes closed without falling may suggest an impaired sense of proprioception. This is a bit wrong in the sense it is it is telling everything related to standing rather than being specific about standing on the foam surface, which could be related to vestibular or neurologic issues. So it is telling impaired sense of proprioception, which could be related to vestibular neurologic issues. Like proprioception is a different sensation, vestibular is not that, so it is not able to resolve that. The positive findings on head thrust testing with refixation saccades and the movement of the optic disc during ophthalmoscopic testing of VOR further support the possibility of vestibular. This is spot on. It is clearly telling both these findings are related to vestibular dysfunction. Okay, though we are talking about optic disc and ophthalmologic testing. Okay, clearly an ophthalmic-like testing, but the model knows that it is actually related to VOR. Additionally, the patient's decreased audibility, because here nowhere did we mention that our relation to the head. Okay. Additionally, the patient's decreased audibility to finger rub in both ears might indicate some degree of hearing loss, which could be related to the patient's previous exposure to gentamicin or due to age-related factor. A thorough evaluation by neurologist, otolaryngologist, or specialist in neurotology is recommended to determine the exact cause of the patient's symptoms and to develop an appropriate treatment plan. This may involve additional diagnostic testing such as audiometry, vestibular function test, caloric, V8. Just see the difference of vestibular function tests that were suggested for the previous question versus this question. In this question, it is clearly telling, previous question, it was telling do a video nystagmography to rule out any vestibular abnormality. Here it is being specific because it knows that, okay, possibly the model has been prompted not to give a specific diagnosis. It's been now, something has been done to not mention a specific diagnosis upfront, because everything else tells that this model possibly knows the specific diagnosis, because it is telling suggesting caloric testing, suggesting VHIT, suggesting WEMP, okay, and imaging studies, MRI. Okay, treatment options for the patient symptoms include vestibular rehabilitation therapy to help improve balance and reduce the risk of falls, as well as addressing any underlying causes, such as medication adjustment or treatment of any underlying neurological conditions. If the hearing loss is confirmed, the use of hearing aids or other assistive devices may also be considered. Now, what I did is, I wanted to study the difference in response of GPT-4 to GPT 3.5. So I asked the same question to model GPT 3.5. So same question, I will not go through the history. Then it appears the patient is experiencing oscillopsia and gait instability. This is what we told. But it is telling oscillopsia refers to an abnormal visual sensation in which objects appear to be constantly moving, often caused by disruption of vestibular system, which is responsible for maintaining balance and spatial orientation. Gait instability, on the other hand, refers to difficulty maintaining balance while walking, which can result in falls and injuries. The patient's symptoms appear to be worse in dimly lit environment, and when walking on uneven surfaces, suggesting that his balance and spatial awareness are being impacted by visual cues. Okay, it should have been written are being impacted by loss of visual cues. Okay. Additionally, the patients reports difficulty in complex visual environments such as glasses, which may further contribute. This is where the visual cues are impacting him, not dimly lit environment. Okay. The patient's history of ileostomy and postoperative infection with gentamicin is noteworthy, as gentamicin is an ototoxic antibiotic that can cause damage to the inner ear and disrupt the vestibular system. Patient's previous experience of oscillopsia and gait instability during that time may be related to this. Overall, the patient's symptoms suggest a possible vestibular dysfunction. Okay. So now this is what. Then same, I repeated the same question. Then again, it told may have vestibular dysfunction, all these things, increased, decreased audible, general comment. But it used to again and again tell the refixation saccades noted with head movement to right and to left on head thrust testing suggests a deficit on VOR. Here it is clear compared to this thing, which is responsible for stabilizing the eyes during head movement. The movement of optic disc with head movements during ophthalmoscope testing of the VOR, okay, confirms this deficit. So again, it is it knows the actual meaning of that particular test. Here, the patient's inability to stand on a compliant foam surface with eyes closed without falling suggests a significant balance impairment. This, along with other neurologic exams, supports the diagnosis of vestibular dysfunction. So, previous versus this one, that was more proprioceptive, a lot of other things. Here, in this deep 3.5 model, it is being more clear that this is related to the vestibular dysfunction. Okay, then it tells go to a health professional. Now I'm asking, oh, you are simply telling vestibular. I'm really not happy. I want to force it to think what exactly is the type. So can you suggest any specific type of vestibular dysfunction likely in him? Now comes the diagnosis. When I prompt it, no, I want what you are thinking underlying. Let me know what you are thinking. Then it tells, based on the provided information, it is possible that the patient is experiencing bilateral vestibular dysfunction. But then it gives that, which possibly means that the model knows that it is dealing with bilateral vestibular dysfunction, because most of the other investigations, it suggested so many things that it took were all actually very clearly meant for bilateral vestibular dysfunction. Maybe it has been now told not to offer a specific diagnosis, something like that could be happening. Okay. Then the patient's history of all these gentamicin, all these things, okay, a lot of good comments are there. But I'm asking further question. Okay, you said it is bilateral vestibular dysfunction. How sure are you? I wanted to be sure. So I asked the question, does it fit the criteria of bilateral vestibulopathy? And here comes the answer. Yes, the symptoms and examination findings described in the case do fit the criteria of bilateral vestibulopathy. Bilateral vestibulopathy is characterized by bilateral erection or loss of vestibular function, resulting in chronic balance disorder that causes oscillopsia, gait instability, and difficulty with spatial orientation. The patient the patient in the case presents with oscillopsia and gait instability with a widened base and difficulty standing on a compliant foam surface with eyes closed without falling, which are all consistent with BPP. Now see, it is telling these are all findings of actually BPP. When you prompt it, it is telling you the presence of refixation occurs with head movement, the inability to maintain the stability of optic disc during ophthalmoscopic testing of the VR, and the decreased audibility to finger rub in both ears are consistent with the diagnosis of bilateral vestibulopathy. Therefore, it is possible that the patient may be experiencing bilateral vestibulopathy. Further testing such as ENG, VNG, and vestibular evoked myogenic potential can help confirm the diagnosis and determine the underlying cause of the patient's vestibular dysfunction. In this particular 3.5 model, it was not exactly telling the caloric testing and head impulse test. 4 model was actually able to tell the caloric testing and the actual. Okay, if I remember well, yes. So only the 4 model was able to tell the specific diagnostic tests that are needed. These are more generalized comments, but it is able to tell whether it is fitting the diagnostic criteria. It is able to give a more specific diagnosis when it is prompted without actually mentioning the specific diagnosis. These kind of things. Now, simply, I just wanted to play with it. I wanted to see if it has any inherent biases or whatever it is. So I just do this. Simply asked a question. How helpful is Cyclops MedTech's balance eye? Okay, just see. And see, as an AI language model, I can provide information about the features and capabilities of Cyclops MedTech's balance eye, but I cannot provide a personal opinion on how helpful it is, as I do not have personal experiences or biases. It tells balance eye is a medical device developed by Cyclops MedTech that uses eye tracking technology to detect and diagnose vestibular disorders. The vestibular system helps us to maintain our balance and spatial orientation, and disorders in this system can lead to problems with balance, dizziness, and other symptoms. The balance eye system uses a non-invasive test that involves the tracking of the movement of a patient's eye while they watch a moving visual stimulus. The device then analyzes the eye movements to detect any abnormalities in the vestibular system. Studies have shown that balance eye has high accuracy in detecting vestibular disorder and can help, which means it has actually gone through the studies and is telling, okay, make more accurate diagnosis. It may also reduce the need for more invasive diagnostic tests such as caloric testing. Overall, balance eye has the potential to be a useful tool in diagnosing and managing vestibular disorders and may help improve patient outcome. However, As with any medical device, its effectiveness may vary depending on individual circumstances and the expertise of the physician using it. Okay, so that's a very nice answer coming from an AI model. It knows, it has studied, including some studies, and then able to tell it is as good as the physician that is using it. Okay, it depends on the expertise. So there are two more questions that I asked. Okay, to check to stretch to where it goes. I wanted to know to what extent, whether it can really be specific. Okay, bilateral vestibulopathy, it was not. Okay, orthostatic hypotension in the beginning, it just gave the moment the information was adequate information. Bilateral vestibulopathy, when you prompted, it gave the term. Orthostatic tremor, when you gave the finding, it gave. Let us see how far it can give the diagnosis. A 58-year-old woman who did not work outside the home complained of frequent falling. The patient's symptoms had begun several years previously, were gradually worsening, and did not fluctuate on a day-to-day basis. There was particular difficulty going downstairs and stepping from the sidewalk to the street. The patient's spouse stated that she had some slowing of mentation and slurred speech. The patient had no complaint of vertigo or hearing loss or tinnitus, no medical history of significance, and no family history of neurologic or otologic disease. The patient's primary care physician had performed a CT scan, which was normal, and had given the patient a diagnosis of Parkinson's disease. The patient had not responded to dopaminergic or anticholinergic agent. So when I provide this, there are some things which is very clear to the model, and let us see how clear it is. Based on the information provided, it is unlikely that the patient has Parkinson's disease since she did not respond to dopaminergic and anticholinergic. It is telling why the patient is not likely to have and why it thinks that it is not likely to have. Okay, so a lot of learning has happened there. Moreover, Parkinson's disease is typically characterized by tremors, rigidity, and bradykinesia, and not just falls and difficulty with stepping. This also, see, falls in Parkinson's disease is a late finding, and by the time the falls happen, other signs would have happened. So model seems to know that. The symptoms described in the case suggest a possible cerebellar disorder or ataxia, which affects coordination and balance. This is what it is thinking so far. Cerebellum is responsible for coordination of movement and balance, and damage to this area can result in difficulty with motor control. The patient's symptoms of slurred speech and slowing of mentation also support a cerebellar disorder, possibly. Okay, that is what it is thinking. And then it is asking additional tests such as MRI of the brain, EMG, or a nerve conduction study may be necessary to confirm the diagnosis. A referral to a neurologist or a movement disorder specialist may also be helpful in managing the patient's symptoms and developing a treatment. Now, to this model, I'm going to give, after this information, some additional examination finding information. Okay, let us see. Let us challenge each one of us, ourselves. Let us challenge and let us see what diagnosis we come to and what diagnosis the model comes up. Okay, let us take this as a challenge to see where we are and where the AI model is. Okay, just take up this challenge. The general examination revealed a disabled woman who appeared to be depressed. Neurologic examination revealed limitation of vertical gaze, especially downward gaze during voluntary movements. There was a severe slowing of vertical saccades and minimal slowing of horizontal saccades. Square wave jerks was noted. There was saccadic pursuit and abnormal convergence. Doll's eye, that is oculocephalic reflexes, revealed a full range of extraocular motion, vertically and horizontally. Bell's phenomenon, that is up gaze during blinks, was absent. Patient had a masked faces with a decreased blink race. There was a hyperactive gag reflex. Motor system examination revealed increased tone with increased deep tendon reflexes that were symmetric. The plantar response was equivocal bilaterally. Sensation was normal. Coordination revealed slowing of an alternating movement and slowing on finger nose testing without dysrhythmia. Romberg test was negative. Evaluation of the patient's gait revealed a widened base, short stride length, and retropulsion. The otologic examination was normal. When this amount of information was provided, just for the sake of practice, where we are, where the AI model is, okay, at least in some places, okay, maybe you all can write down what you are thinking of the diagnosis and let us see. Okay, if you've done that, then I'll show what the model comes up with. Based on the neurologic examination, the patient's symptoms are consistent with progressive supranuclear palsy. And in this particular patient, in the textbook by this particular authors, the diagnosis is this one only, PSP, progressive supranuclear palsy. So it is spot on the moment this amount of information is given. The PSP is a rare neurodegenerative disorder that affects the movement, balance, and eye movements. The clinical features of PSP include vertical gaze palsy, slowing of vertical saccades, square wave jerks, abnormal convergence. Additionally, PSP can cause Parkinsonian symptoms such as masked faces or hyperactive gag reflex, as well as gait disturbances, including a wide and base, short stridor, and retropulsion. The absence of hearing loss or tinnitus on otologic examination rules out an inner ear problem as the cause of the patient's symptom. The equivocal plantar response may suggest an upper motor neuron lesion, which is again consistent with diagnosis of PSP. Further testing such as MRI of the brain may be necessary to confirm the diagnosis of PSP. Referral to a neurologist or a movement disorder specialist can help manage the patient symptom and provide appropriate treatment. Unfortunately, PSP is a progressive disease and there is currently no cure for the condition. The treatment is mainly supportive, aimed at managing the symptoms and improving the patient's quality of life. So the moment this amount of information is provided, it is able to tell. But what we need to actually evaluate is, once this much is given, it is able to give general suggestions, but is it able to really specifically tell, okay, what needs to be done, what additional questions that should be asked? Okay, that is the future. The future is where it becomes able to tell, please ask these questions and get back to me. Okay, I want this information. This is the information we have provided, and all this information was not actually sought in this question. There are some general information that is sought, but specifically what information we provided was not sought. So the future of these models would be to seek out that specific information before it actually gives the diagnosis. Okay. Then there is the last. Okay, this again, I did a little bit of more, a little bit different query. Clinical history, everything was there, but just wait for the end. A 70-year-old man presented with episodic dizziness. The patient's symptoms had, just give me 1 minute. Okay. Yeah. A 70-year-old man presented with episodic dizziness. Patient's symptoms had been particularly troublesome during the last 6 weeks. He described spontaneous episodes of occurring about twice a week, characterized by acute onset of vertigo and a tendency to fall to the right, lasting for seconds to a few minutes. There were no clear precipitating factors such as changes in head posture or standing after sitting or lying down. The patient had no complaints of hearing loss or tinnitus. His history was significant for hypertension and a peptic ulcer disease. Current medications included an angiotensin converting enzyme inhibitor and an H2 blocking. So whether this model knows this pattern and what this pattern represents. Okay, the patient had that has episodic dizziness, which has been troublesome in the last few weeks. Does this model know what it means? Okay, and here it is clear that so far the model does not know. So based on the given information, the 70-year-old man's symptoms are suggestive of peripheral vertigo. So it is simply being more generalistic. The acute onset of vertigo and tendency to fall to the right, indicating a fall of a dysfunction in the vestibular system, which is responsible for maintaining balance and spatial orientation. Fact that the episode occurs spontaneously, not associated with changes in head position, suggests that problem is not due to BPPV, which is a common cause of vertigo that is triggered by changes in head position. So it is at least telling what the patient does not have. Patient medical history, significant hypertension and peptic ulcer disease, which may be relevant in the differential diagnosis in the cost of. So it is telling maybe these things you should consider as the cause of his symptom. Medications such as ACE inhibitors and H2 blocking agents may also contribute to development of vertigo. It is telling what else can cause. Because if the person is having hypertension and peptic ulcer, maybe for hypertension you are giving ACE inhibitors, maybe for peptic ulcer you are giving H2 blockers, and maybe those can actually cause development of vertigo, is what it is suggesting. Maybe you should consider that. So I have to verify whether I personally don't know, so I have to verify whether it causes. I can ask the model itself to verify, but I have not done that. Further evaluation is warranted to determine the underlying cause of patient's vertigo. A comprehensive neurologic examination, including assessment of cranial nerves and cerebellar function, should be performed. Imaging studies such as MRI and computer tomography may also be useful in ruling out structural abnormalities. An audiogram may also be helpful in evaluating a hearing loss, which can be associated. So, a comprehensive neurologic examination, including assessment of cranial nerves and cerebellar functions, it is asking for this particular information. So let us provide some additional information. Upon careful questioning, the patient noted that with several of his vertigo, this is the question that we asked. The model should be able to ask us what information it wants, and seems to be asking, though not directly, that this assessment is required. Something about cerebellar status, something about the cranial nerve status. So upon careful questioning, the patient noted that with several of his vertiginous episodes, he had experienced circumoral paresthesias. Okay, so if you think about cranial nerve, any numbness, we would have asked. Okay, and patient is telling circumoral paresthesia. And on one occasion, double vision. is family related that during some of the patient's episode, his speech was often difficult to understand and he walked like he was drunk. So these are cerebellar. It didn't specify what cerebellar to ask for, what questions to ask for, what examination to do, but it gave an indication as to look for cranial nerves and cerebellar function. And we are providing that particular information actually related to cranial nerve and cerebellar function. The patient had no family history of neuro. The moment this was given, just see what is happening. The new information provided to patient regarding circumoral paresthesia and double vision, along with the family's observation of difficulty in speech and unsteady gaze, raises concern for a possible central cause of vertigo. So it has changed this opinion. Previously, it was telling peripheral, now it is causing central cause of vertigo. This suggests that the vertigo may be originating from a lesion or dysfunction within the central nervous system rather than the peripheral nervous system. The fact that the patient has no family history of neurological or otologic disease is helpful in ruling out some hereditary conditions that may cause vertigo. However, a thorough neurologic examination is necessary to assess for any focal deficits or signs of central nervous system dysfunction. Further testing, such as magnetic resonance imaging of the brain with contrast, may be indicated to evaluate possible causes of vertigo, such as a stroke, multiple sclerosis, or a brain tumor. Other tests, such as blood tests and electrocardiogram, may also be ordered to rule out underlying medical conditions that may contribute to vertigo. In summary, the new information regarding circumoral paresthesia and double vision, along with the family's observation of difficulty in speech and unsteady gait, raises concern for a possible central cause of vertigo, and further testing and evaluation is done. So it is really not caught the actual pattern that this means. It is telling, in the beginning, it was telling peripheral, then it sought some information. Based on the information provided, it changed the opinion to central, but it is still not being specific. Now we have give more information. The patient had entirely normal general neurologic and otologic examination, with the exception of several soft neurological signs, including a very mild left pronator drift and an equivocal Babinski sign on the left. There was no orthostatic hypotension. There were no carotid bruit. The patient had a slightly widened base to his gait. Neurotological examination, including Dixalpic maneuvers, was normal with the exception of difficulty standing on a compliant foam surface with eyes closed. Now, what does it tell? The normal general neurological otological examinations are reassuring, but the presence of soft neurological signs such as mild pronator drift and equivocal Babinski sign on left that suggests there may be some central nervous system involvement. The difficulty in standing on a compliant foam surface with eyes closed suggests possible impairment of proprioception of balance control, which could contribute to a patient's episode of vertigo. It is not a correct interpretation. The absence of orthostatic hypotension or carotid bruit are helpful in ruling out certain cause of vertigo, but further testing may still be necessary to determine the underlying cause. Given the patient's age and history of hypertension, cerebrovascular disease remains a concern. So here it is becoming very specific that it remains a concern. An MRI of the brain with contrast may be indicated to further evaluate possible central nervous system lesions or dysfunction. In addition, vestibular function testing such as ENG, VNG may be helpful in evaluating any peripheral dysfunction. Overall, the presence of soft neurological tension, difficulty with balance control suggests there may be some central nervous system involvement contributing to patient symptoms. Now, we provided more information. VNG, normal. Rotational, normal. Audiometry, bilateral high frequency, SNHL, MRI scan revealed old infarction of the right frontal lobe, right internal carotid artery occlusion, bilateral white matter hyperintensities in the periventricular white matter. There are no obvious abnormalities in the brainstem or cerebellum. An extracranial MRA revealed right internal carotid artery occlusion. An intracranial MRA revealed ectatic right vertebral artery and narrowing of the basilar artery. Now, what is the way that this interprets all this investigation? The VNG results show normal ocular motor, positional and caloric test, as well as normal rotation, suggests that there is no peripheral vestibular dysfunction contributing to patient's vertigo symptom. The presence of bilateral high-frequency sensorineural hearing loss on audiometric testing is consistent with presbyocusis, which is age-related hearing loss, but it is not likely to be the cause of the patient's. It is telling it is an incidental finding. It is not related to the patient's complaint. This is perfect interpretation. The MRI scan of the head reveals an old infarction of the right frontal lobe, right internal carotid artery occlusion, bilateral white matter hyperintensities in the periventricular white matter. These findings suggest that the patient may have suffered from a previous stroke, which may have caused the central nervous system dysfunction, contributing to his vertigo symptom. Possible. The previous stroke is causing, but it is really not reached what exactly is causing the problem. But it is very, very close. It is telling it means cerebrovascular. Okay. The extracranial MRI findings of right internal carotid artery occlusion and intracranial MRI ectatic right vertebral artery narrowing of basilar concerning for vascular disease, which may be contributing to patients. So here it is becoming that specificity is reaching. Okay. Further evaluation by vascular specialists may be warranted to determine the appropriate treatment for the patient carotid artery occlusion and possible cerebrovascular disease. Additionally, the patient may benefit from vestibular rehabilitation therapy to improve his balance and reduce the frequency and severity of his vertigo symptoms. In summary, the video stegmography results suggest that the patient's vertigo symptoms are not due to patient's peripheral vestibular dysfunction. The MRI findings of an old infarction in the right frontal lobe and white matter hyperintensities, as well as MRA finding of carotid artery occlusion and narrowing of the basilar artery, suggests that the patient may have suffered from a previous stroke and may have underlying vascular disease contributing to his symptom. So it is telling that this could be contributing. Now I'll ask a further question. So this is the thing that I was waiting. Can you find any citations that support the possibility that ectatic vertebral or basilar, whatever I just typed it up, basilar, ectatic basilar artery can cause episodic vertigo? Can you find a citation? Because we got this finding, it is generally telling. Now I want to be sure. Maybe I'm thinking ectatic basilar artery. So I'm asking the question. While the literature on the relationship between ectatic basilar artery and episodic vertigo is limited, there are some case reports and studies that suggest possible association between the two. One case report published in Journal of Stroke and Cerebrovascular Disease in 2017 described a patient who presented with recurrent episodes of vertigo and was found to have an ectatic basilar artery on MRI. The authors of the report suggested that the ectatic basilar artery may have been causing compression of the adjacent vestibulocochlear nerve, leading to the patient's vertigo symptoms. Another study published in the Journal of Neuroimaging in 2011 reported a case series of 3 patients with ectatic basilar artery who presented with various neurological symptoms, including vertigo. The authors suggested that the ectatic basilar artery may have been causing local compression or irritation of the adjacent structure, leading to the patient's symptoms. However, it is important to note that these reports are limited in number and do not provide strong evidence for a causal relationship between ectatic basilar artery and vertigo. More research is needed to better understand the relationship between these two. And the references are actually given. Ectatic basilar artery causing recurrent vertigo. A case report by Mantica. Then ectatic basilar artery presenting with cranial nerve palsies and vertigo. Report of 3 cases. This is Garg, Panda, and Sharma, Journal of Neuroimaging. So this is the kind that it can. Okay, you can ask more questions. Today I just thought, okay, there is some 1 hour of time. I will challenge this model with case histories and specific to vertigo and see what exactly the model is able to come up with. And this is what it was able to come up with, which is quite impressive. It is quite impressive. It actually tells that, gives us suggestions how all you can. Okay, instead of going to Google search, looking for what all citations are possible, you can just ask the ChatGPT model, just give me some citations of, say, if you want to find out about central causes of BPPV, tell me some examples of post-cranial fossa lesions presented. Give me some citations of case reports of post-cranial fossa lesions which presented as BPPV. It will find. Tell me some case reports of, find some case reports of idiopathic intracranial hypertension presenting with vertigo, then it will go and find. So these are the things that it is capable of doing. But then we'll have to always have that additional, we'll have to check whether what it found actually has that or not. So that that we need to do. Okay, that much care we would have to give. But then see, to some extent, personally also, I find that it actually works like a senior colleague giving response. Okay, and it is definitely more involved because it knows the full information. Okay, if somebody calls me about a particular case, to the extent that I can concentrate at that particular time, it changes with how tired you are on that particular day, how good was the day, all those things are there. Whereas when it comes to AI model, that doesn't, that is not the case. Okay, it's always fresh. So these things are there. And I think all of us should start exploring ChatGPT, start playing around with it. If not anything, at least it's a very good summarization of investigation. So if you have a patient and you've done so many investigations, feed all those investigations, it will at least give you the summary of the investigation and interpretation of the investigation, which you can actually cross-check. And if the interpretation is right, minimum it would have done is it would have been a very good writer for you. Okay, in the sense, in summarizing things and everything, saving time. All that you need to do is give some oversee that what it has written is correct, and then the same thing can be taken down and written there as your discussion about the patient. To that extent, of course, we have to give enough caution to make sure that we have read every line and it is consistent with what you are thinking. But then it is quite amazing the way it could tell that it is a PSP. Only thing is, in the days to come, it will tell, okay, your patient does not have Parkinsonian, but looks like Parkinson's, but looks like Parkinsonian. When you're looking for Parkinsonian, it's very important to look for eye movements. Please look for this particular kind of eye movement and let me know so that I can give you a diagnosis. Those days will be coming, okay, is what I think. The future, those kind of days also will be coming. So what is going to happen? Is artificial intelligence going to replace us? No, artificial intelligence is not going to replace us or our jobs. But what is going to happen is, definitely the people who are using AI will definitely slowly start replacing people who are not using AI. So it is very, very important to start adopting this and start using it, start leveraging it for doing the work, because if not anything, the amount of time that it saves is going to be huge. Okay. In fact, if there was more time, I would wanted to do a live demo of asking for interactions. Tell me, in this particular elderly man who is actually already taking an angiotensin converting enzyme, whether I can add a particular drug, okay, like amitriptyline, and then seek the suggestions. These kind of live demos I wanted to do. I tried asking one question live. The model was not responsive. Maybe there are a lot of queries coming at this time. Sometimes that happens in this model. But then I think this was a good enough overview for those people who are new to ChatGPT. But if you're not new to ChatGPT, maybe something it has added already to what you've been doing, or what kind of benefit that I have been getting, which you can use. If there are some thoughts that the way you have been using, Vishnu's number is there, you can always share. Today, I will not be in a position to take many questions because I have a bus to catch. Immediately now, I'll have to log out and start for the bus stand. So please excuse us. I think there was in the chat box, there was a question about the book name and all those things. Vishnu will write his phone number. Vishnu will write his phone number in the chat box. Please take down his phone number, get in touch with him for the details of the book. Okay. And if there are any comments also, please do, please do pass it on. Okay. So thank you so much. So one thing is, okay, if you are an introvert, you don't want to ask questions to anybody, you can at least ask ChatGPT, and there are some things that it will come. Okay. Dr. Ravi Obishetty, I think you can get in touch with Vishnu. Vishnu will write. Vishnu's phone number is there. He will share the details. Okay. So thank you so much. Okay. Thank you all. So please excuse the fact that I'm not able to take questions or take any discussions as of now. So because I have to log out and okay. 3.5 or you can choose which model you want to use. Okay, you can definitely choose which model, 3.5 or 4. Okay, it is left to you. But personally, I think for simple questions, I think 3.5 does better. Okay, if there's complicated, then 4 does a better job. But for simple questions, 3.5 does a better job. Okay. So that's it. You can even go for a premium subscription. It's not really costly. And definitely, but Google does not go away. Google still stays. Google is good enough. But there are so many places where this will make our job very, very fast. So thank you all. Thank you for coming. Okay, thank you all. So let's, I think if with your permission, I will take leave and we will end this session. Thank you all. Thank you so much. Vishnu, I think you can keep the thing on for another 2-3 minutes for people to take down your phone number. After that, you can end. I will be leaving. Okay. Thank you all.
Yeah, sure. Okay.